Madam President, I rise today to discuss a bill that I'm introducing called the Co-Prescribing Saves Lives Act. All across the nation, and certainly all across my Commonwealth, we're seeing the scourge of prescription drug abuse and a heroin epidemic. These opioids are having major impact in communities everywhere in Virginia, from coal mines of Appalachia to rural communities in the Shenandoah Valley to right here in suburban Fairfax County. And I have heard, and I think my colleagues in this body have heard, stories from parents who've buried children, from companies that can't find employees who can pass drug tests, and certainly from law enforcement officials, judges, prosecutors, police officials, sheriffs, who talk about the dramatic expansion of opioid addiction in this country. The numbers are kind of shocking. When I came to the Senate and started doing tours around the state in the spring of 2013, I really wasn't kind of schooled about this, and I started to hear stories. Heroin and opioids now account for 25,000 American deaths a year, and in Virginia and in much of the United States, the deaths from opioid overdoses are now exceeding motor vehicle accidents, deaths from motor vehicle accidents. According to the Centers for Disease Control, in the U.S., fatal opioid-related drug overdose rates have quadrupled since 1990 and have never been higher than they are right now. So the question is, how do we address this crisis? And obviously the answer is there's no single answer. There's a lot of things that have to be done. Federal government, state and local communities, faith communities, nonprofit organizations, families, individuals educating themselves. There's a lot of answers, but we've got to move forward on steps that we know can reduce overdose deaths. There is some good news. There are advances that can help us do this, and one of the advances has been the development of a drug called naloxone, which is a medicine that is safe and effective as an antidote to all opioid-related overdoses, including heroin, prescription opioids, and fentanyl. And it is a critical tool. It's proven a critical tool since its development in preventing fatal opioid overdoses. One of the neat things about naloxone is if you come across somebody who's in respiratory failure, and it could be from an overdose or it could be for some other reason, you can administer naloxone to that individual, and if it's not an overdose, it doesn't have any negative side effects. It can bring somebody back from the overdose-caused respiratory failure, but it doesn't have negative side effects if it turns out the person is suffering from something else. In Virginia, there's an organization called Project Revive that trains people to administer naloxone, and in one of our communities in Russell County, far southwest Virginia, about a year ago, I took the training with a lot of family members and others, just 2-hour training to learn how to do this. Since naloxone has sort of been developed and really come into more common usage beginning in the late 1990s, it has saved more than 26,000 people who've been in the throes of an overdose. Naloxone has brought them back to life. And I think a lot of professionals, public safety professionals, healthcare professionals around the country have seen how effective it is. So the answer, one answer to our overdose problem is to co-prescribe naloxone when someone is getting a prescription for an opioid. And opioids have legitimate uses to manage pain. When somebody's getting a prescription for that, to co-prescribe naloxone so that they can have the antidote right there in case of an overdose. And I know that, Madam President, you understand this. There are overdoses from people who are, using drugs inappropriately and grabbing somebody else's prescription and using opioids. But there's also overdoses, quite a few happen, with people who are legitimately prescribed the drug, and they're usually prescribed it for pain. They develop a tolerance for the drug, and so the package may say take 1 pill every 6 hours, but the pain is strong, and after 3 hours you start to feel it again, and somebody thinks, okay, well, the drug's worn off now, so I can take another one. And you can start to take too many because of pain symptoms, and you get into an overdose situation for that reason too. But if you have a naloxone co-prescribed, you can have the antidote right there that you can administer to yourself or someone else can if you get into an overdose situation. Many communities, states, and national organizations and medical organizations have supported co-prescribing naloxone to patients who are taking opioids as a critical part of this overdose problem. And you have guidelines. Not everybody who gets an opioid prescription needs naloxone. My wife broke and dislocated her shoulder 2 Good Fridays ago, and she got prescribed a powerful opioid painkiller, and she used about a day and a half's worth of it and made her sick to her stomach, so she quit using it. Not everybody who gets prescribed a prescription opioid needs naloxone, but there are certain warning signs, and the medical profession has kind of developed the warning signs, or if you have these signs, you should get the co-prescription. Developing these guidelines helps physicians, pharmacists, and other providers determine who is at risk and who we should be proactive with the co-prescription. So, what this bill does is the following. It improves access to naloxone by encouraging physicians to co-prescribe in a couple of circumstances. To co-prescribe this life-saving drug alongside opioid prescriptions and making it more widely available in federal health settings. The Co-Prescribing Save Lives Act would require that the Secretaries of Health and Human Services, Defense, and Veterans Affairs would establish physician education co-prescribing guidelines for all federal health settings, including VA hospitals, DoD hospitals, the Indian Health Service, and federally qualified health centers. So within federal healthcare facilities, if there's going to be an opioid prescription to somebody in a high-risk situation, there would be a mandate that naloxone would be prescribed as well. Now, this builds upon work that's already been done in the federal government, especially the VA has been a real leader in setting up these co-prescription guidelines. In addition, the bill would provide a program of grants through state departments of health that are interested in doing the co-prescribing guidelines for private physicians, not in federal settings in their states. The funding would allow states to purchase naloxone, to provide copay assistance for uninsured patients, to fund training for health professionals and patients, and grant funding could also support state innovation and provide for community outreach. The kind of program where I trained last summer, Project Revive, is just a community program trying to battle overdose deaths in the coal fields of Appalachia. That would be the kind of program that if other states wanted to do that, could be eligible for grant funding. In closing, this is just one solution. Obviously, the real solutions, the important ones, are still around prevention. Why do Americans get prescribed so many more opioids than folks in other nations? What do you do about prescriptions when the quantities that are given are too big, and then you end up with a lot of unused opioids that can be taken by young people or stolen and sold? There's a lot of issues that we have to solve. But there is this bit of good news, that naloxone saves lives, and if we can, it's easy to administer, it doesn't have a negative side effect, and if we can broaden access to naloxone for those who have been prescribed opioids, we've saved lives in the past, and we're going to save a lot more. I'll just conclude by saying there's a dad in Northern Virginia, a guy by the name of Don Flattery, who has been very public about the loss of his son, Kevin, who was a 26-year-old graduate of UVA in 2014. And he talked about his son, and the family and the advantages they had and his educational track record of success at UVA. But then he fell into the just bottomless pit of prescription opioid addiction, and he perished in 2014. And what Don said is, I feel we need to keep personalizing what is happening. We're not addressing shocking, obtuse statistics. We're speaking about my son, your daughter, our neighbors. They're real people with real lives, and their losses are the face of the epidemic we must stop. That's what this bill intends to play a part in, and with that, Madam President, I yield the floor.